a newly implemented system of monitoring prescriptions of potentially dangerous drugs. It has uncovered over 27,000 people at risk of harm just in April and just in Victoria, and the rollout is far from complete. So that's an underestimate of the real extent of the problem. The problem is potential overconsumption through doctor and pharmacy shopping and dangerous combinations of medications. If I can give a bit of a backstory to how we came to the drugs, because that's important. We commissioned a review from Austin Health and they looked at 4 different sets of data. They looked at coronial data of course, but they also looked at paramedic data, data from the poisons information centres across Australia, and inpatient data as well. From that they synthesized a list of their medicines causing most harm. Harm being a number of different things, but death obviously from the coronial report, but just the fact that particular medicines were present with paramedic call-outs, also within the poisons information centre people who were calling up with adverse effects from whichever medicine. But from that list, that synthesized list, we took that then to our expert advisory group, which gave us their recommendations about which needed to be in and which didn't. We knew it was important that the evidence base was behind that. So the ones that are in are all the prescription opiates, and that includes combination analgesics with codeine. Now on prescription rather than over the counter. That's right, because, indeed, codeine is no longer available over the counter. But, the prescription opiates, all benzodiazepine. So just stick with the opiates for a moment. So that's oxycodone, in done it's called, and fentanyl, and the sort of problems you're seeing in massive proportions in the United States but not in significant proportions here. That's right, the slow-release oxycodone as well, a number of different brands of that, slow-release oral morphine, fentanyl, as you mentioned, any of the prescription opiates that are classified as Schedule. So, moving on from those, also all benzodiazepines, diazepam, alprazolam, you'd know brand names like Xanax and Valium. Also cousins of the benzodiazepines, which are called the Z-class drugs, they are for sleeping, zopiclone and zolpidem. What are the brand names of those, just so we recognize them? I was trying to remember zolpidem. Is it Xanax? Well, it doesn't matter. Trying to guess live on air is not really a good idea, but they are common once prescribed. They are indeed. And finally one single atypical antipsychotic is also included, quetiapine, and that brand name is Seroquel. So that's used unfortunately too much with people with dementia, but it's also used to treat psychosis and other situations. That's right, a fair bit of off-label prescribing as well. So how does SafeScript? At its core it is an IT system, a database. So every time a prescription is dispensed, that information is then into SafeScript, so that each time a doctor goes to prescribe or a pharmacist goes to dispense, that information is available to them at that point of decision, and whether they wish to prescribe or whether they wish to dispense. The technology is important though, because we've got a very clear, strong message from our advisory group right from the get-go that needed to be as seamless a process as it possibly could be. So the technology that we've developed, the most seamless interface, and that is with the majority of the clinical systems out there in primary care settings, is one. So it goes onto the doctor's computer and the pharmacist's computer, and the systems that they use. It's called Medical Director or Best Practice. Or Best Practice or any of those. And there's about 9 of them in pharmacies. So they prescribe from the dot. Let's say the doctor prescribes from his or her computer program, Medical Director or what have you, and they are going to prescribe and done. That's right, so the minute they've typed in the drug, their system knows that it is a monitored medicine. So there's then two-way messaging between their clinical system and SafeScript, and they will get a push-out notification. So they are not needing to go to a separate system, they are not needing to do a separate login. And what's the notification they get? You're the third GP that Mrs. Jones has gone to, for and done. We use a traffic light system, so if there's nothing in the database at all they'll get a green notification. If there is some records there but nothing too risky, they will get an amber notification. And then there are a number of circumstances which I can describe which will trigger a red alert. And with that red alert, that is what is deemed a high-risk circumstance, and they need to go to SafeScript and look at the full database records for that patient before they proceed. And that could be that they've been doctor shopping, or that somebody else might have prescribed another drug which could interact with this one. So it might be quite benign, in a sense. They might not the doctor shopping, but they might inadvertently be getting another prescription for something that might react with another drug. Norman, I'll just say one thing if I can quickly while you're saying that. We are fairly conscious of the use of language which might be stigmatizing to patients, so we try to avoid the term doctor shopping. We talk about multiple provider episodes. So one of the circumstances that will trigger a red alert is if they have seen more than 5 prescribers in the last 90 days, so that's one. Another one is it also runs rules around morphine equivalence if they are on more than one different opiate, and it will calculate the daily dose of morphine equivalence for that patient, and if it's above 100 milligrams of morphine equivalence, which was what the Hunter New England guideline said was the maximum safe dose, then that will trigger a red alert. It will also trigger a red alert with certain combinations such as fentanyl and methadone. This is going to be compulsory next year, but so far you've got limited penetration in both pharmacy and general practice. About 1 in 4 GPs in Victoria so far. So we sent out an email to all registered medical practitioners and pharmacists who listed Victoria as their primary place of practice in the start of April. So that was around 36,000 practitioners, and that's the number who are registered with AHPRA, so that may or may not be the number who are actively in clinical practice, but that's the number we are going on, and around about 11,000 of those have to date registered to use SafeScript. So yes, you're right. How do you manage privacy here? Because people might say, well, what business is it of people knowing whether I've got another couple of prescriptions? It's my business, not yours. It's an issue that we are very, very conscious of. So right from the get-go, the way the system was developed was using privacy by design process. The technology is such that so it's the technology first, the technology is encrypted at rest. So nobody outside. In other words, you're working within a privacy circle of health professionals who in a sense have a right to know for the safety of the patient. That's right, so the safety of the patient, and for them to determine whether it is safe to prescribe or dispense that medicine, they are able to see that. So we also use multifactorial authentication in order for them to log on at the start of the day. So just finally, because we are running out of time, so what are you supposed to do? A pharmacist finds you've got a problem, or a GP finds there's a problem, and people look as if they may have an issue with opiates. What happens next is the critical fact, and that is why as part of the implementation we have rolled out statewide training, and it is to refresh those important clinical skills about what is a safe dose, how to prescribe safely, how to deprescribe, to titrate a dose down if necessary, and how to take someone off an opiates. Well, and how to manage pain properly, presumably. How to manage pain outside of pharmacotherapies. A lot of these people are actually in pain and they are desperate for some effective relief. Indeed. So all of those clinical skills are freshened, but there is another module which I want to plug which is just as important, which is the soft skills, how to have that difficult conversation with a patient. You know, if you've got a patient and all of a sudden you are aware from what SafeScript is telling you that they may have substance use disorder, how do you engage with that patient and actually have the conversation to say, well, maybe we are not going to prescribe that medicine today, maybe we are going to have a different conversation about your health and how we manage that. And very briefly, is there going to be a national rollout of this? We hope so. We are pressing for that. Certainly the Commonwealth has engaged the software vendor that developed the system for us, so it will be available, the same functionality and technology as what we have delivered here in Victoria, and we just